Bismillah ar-Rahman ar-Rahim. First, I'm really honored to have a chance to present in this great scientific event. Thank you so much, my dearest Professor Amal. Thank you for the chairpersons, professors, and colleagues. Actually, my presentation about enzyme replacement therapy as a treatment of Gaucher patient. I know treatment is an important point in each disease, but actually treatment is the end of journey. The journey should start by a good to suspect the disease, gold standard diagnosis, by clinical and the laboratory, and ending the journey by the treatment. So I will start by a small basic clues for the diagnosis and how to suspect Gaucher disease. As you all know, it's one of the lysosomal storage disease, which is a family of many diseases, more than 40 diseases, all characterized collectively by having a genetic background, and it's multi-system and progressive diseases. One of them is Gaucher disease, and the most common type of this Gaucher disease is type 1, representing more than 95%. The lysosomal storage diseases, each one of them is a consequence of type of substrate, where it accumulates in many organs with subsequent organ damage. And this progressive accumulation is the key of the clinical presentation of each lysosomal storage disease. Gaucher disease is the most common sphingolipidosis. It's an autosomal recessive genetic disease due to decreased activity of the lysosomal enzyme glucocerebrosidase. It has many variable phenotypes. The most important is the three type 1, type 2, and type 3. However, these distinctions are not absolute, and it is increasingly recognized that neuronopathic Gaucher disease represents a phenotypic continuation ranging from extrapyramidal syndrome in type 1 at the mild end to hydrops fetalis in the severe end of type 2. So many patients was diagnosed as having type 1 Gaucher disease. After 4 or 5 years, they start to develop ophthalmoplegia, convulsions, or other neurological manifestations and prove to have type 3 Gaucher disease. As an autosomal recessive disease, both parents must be carriers of Gaucher disease with 25% chance that any child of these parents have Gaucher disease. The most common mutations in the GBA gene is N370S, L44B, 84GG, and IVS2. And it has a mild phenotype correlation, phenotype-genotype correlation. The most important is that N370S exclude neuronopathic Gaucher disease and usually had a mild course of the disease, and L44B usually had a neuronopathic Gaucher disease. This is the abnormal engorged Gaucher cells, which is responsible for the clinical manifestation in Gaucher disease. And this is the pathogenesis of Gaucher disease, deficiency of the glucocerebrosidase enzyme, which hydrolyzes glucosyl ceramide into glucose and ceramide. This deficiency leading to accumulation of the glucosyl ceramide. But an important issue is that the enzyme may be normal with the deficiency of the sabotine C, which is the activating protein of the glucosyl ceramide enzyme. This is resulting in accumulation of these abnormal engorged cells by the accumulating substrate in the macrophages, in the bone marrow, liver, bone, lung, and tissue macrophages in the spleen. And the manifestations of the Gaucher disease in adult and children is nearly the same. In adult, the somatic manifestations represented by the hepatosplenomegaly, and the bony manifestation is very common, followed by the anemia, thrombocytopenia, Erlenmeyer, pathological bone fractures, but usually there is a general manifestations which may be only the start manifestations and very confusing in the form of fatigue, bleeding, menorrhagia, decreased appetite, and abdominal pain. In the pediatric age groups, it's the same, but the somatic manifestation in the form of hepatosplenomegaly usually is prevalent. And an important issue in the pediatric is that in the general manifestation, bleed, suspect delayed puberty, and gloss retardation as an important subclinical manifestation of Gaucher disease. However, diagnosis of Gaucher disease can be a challenging task due to its rarity, its unpredictable variable clinical course, and the fact that many clinical signs and symptoms could be difficulty differentiating from other hematological diseases and even some malignant diseases. But the key is a splenomegaly. Once you see splenomegaly, you should suspect Gaucher disease, even if there is anemia and thrombocytopenia. And if it is associated with neurological manifestation, please suspect type 3 Gaucher disease. This is the very common algorithm for the diagnosis of Gaucher disease. Splenomegaly is the keystone for the diagnosis and suspicion of Gaucher disease. So splenomegaly, please think Gaucher. And there is usually a delaying in the period of starting treatment for Gaucher disease reaching up to 10 years, especially in type 1 Gaucher disease. Patients may be referred to several specialists before definite diagnosis. They may refer to orthopedic, hematologist, endocrinologist, and many specialists before we diagnose Gaucher disease. And when we make something like a survey, we ask the hematologist, only 1 out of 5 hematologists suspect Gaucher disease when there is splenomegaly and hematological manifestation. And other hematologists suspect leukemia, lymphoma, multiple myeloma, ITB, and other bleeding disorder before they deviate their mind to Gaucher disease, because they have same manifestations, including the bone pain and the organomegaly. And an important point that is even the bone marrow, when you make a bone marrow examination to definite diagnosis of Gaucher disease and you found the Gaucher cells in the bone marrow, the other diseases have what is called the pseudo-Gaucher cells, which is misdiagnosed as having Gaucher. Why all these suspicion of Gaucher disease? Because the delay in the consequence, the delay in the diagnosis leading to many consequences, including morbidity and even mortality, with hypersplenism, neurodegenerative disease, splenic rupture, Parkinsonism, and many other conditions. Gaucher disease is characterized by variable clinical expression and severity. Even among siblings, there is very weak genotype-phenotype correlations. But the most constant is that type 1 is non-neuronopathic, type 2 had early neurological manifestations and usually fatal, type 3C is characterized by cardiac affection, especially aortic valve calcification. So please, hepatomegaly, hematological fatigue, bone and growth retardation with late puberty, suspect Gaucher disease. And you should differentiate it from other lipid storage disease, specifically Niemann-Pick, Tay-Sachs, and Pompe disease, other hematological, autoimmune, hepatic fibrosis, viral diseases, and anemia of chronic illness. Regarding the diagnosis of Gaucher disease, by simple blood test for enzyme ESHR, acid beta glucosidase ESHR, and an important point is that the residual activity doesn't predict the clinical course of the disease. And this dry blood spot ESHR for the enzyme had benefits and had drawbacks. The benefit is that we can store the sample and send it by regular mail and stored until it required. And it have a very low risk for false negative result. And the limitation is that it has a very relative high rate of false positive. The mutation analysis, it had a definite diagnosis by the DNA. The benefit is mainly the molecular screening for common GBA mutation is very useful for the high risk for Gaucher disease, the relatives of patients of Gaucher disease. And the limitation in sometimes we can differentiate by the true gene affection and the pseudo gene. And also a negative screen by the genetic mutation don't rule out Gaucher disease. And again, there is a weak correlation between the phenotype and genotype. Bone marrow is a definite diagnosis, but it is invasive, especially in pediatrics. And again, don't forget it has a misdiagnosis by the pseudo Gaucher cells for the multiple myeloma, Hodgkin lymphoma, and the other diseases. The biochemical markers is only supportive in the diagnosis. The most important is lyso-GL1. There is biochemical markers which are elevated in Gaucher disease, but not a must. Lyso-GL1, Chi2, angiotensin converting enzyme, tartrate acid phosphatase, ferritin, and polyclonal gammopathy. And there is some markers which are decreased in Gaucher disease, such as vitamin B12, clotting factors, total cholesterol, and of course platelet count. So differential diagnosis again is very having like a puzzle. I wanted to add in the differential diagnosis, when there is a neurological manifestation, please exclude GM1 gangliosidosis and Niemann-Pick type A and type C. And don't forget you have a radiological assessment, performing a pelvic abdominal ultrasound to assess hepatic and splenic volume, its asymptomatic burden of the disease, and echocardiography and plain chest X-ray and CT high resolution if you have a pulmonary manifestation. So a DBS SE is recommended if you have hepatomegaly, splenomegaly, and eye movement disorder, growth retardation, Erlenmeyer, and elevated ferritin and tartrate acid phosphatase. Although bone pain is usually present in most of the pediatric Gaucher disease, but it's more subjective, so don't put in the criterion for suspect of Gaucher disease. So it's very confusing. In children with splenomegaly without thrombocytopenia or anemia, you should exclude malignancy even by bone marrow. If the finding from a detailed medical history, physical examination, and first laboratory test don't suggest malignancy, please proceed immediately to enzyme SE. If malignancy is suggested, biopsy and aspirate should be done from the bone marrow. Metabolic disease, including Gaucher disease, should be considered in the absence of blood disorder, malignancy, and infection. So, why suspect? Why all of this dilemma? Because early recognition of Gaucher disease by physician caring for children is important, because an effective treatment with a favorable safety profile is available. Here is the imiglucerase, which is a very effective treatment, specifically in type 1 Gaucher disease, many clinical trials, and more than 30 publications which recommend and document that imiglucerase is still the current standard treatment for Gaucher disease type 1, and the recent available treatment don't show better result in hematological, visceral, and bone marrow, and it also enhances the quality of life versus growth retardation, safe and well tolerated. It mainly affects the somatic manifestation in the form of hepatic and splenic volume. It normalizes the hepatic and splenic volume, and also affects the hematological parameter, making the hemoglobin and the platelet count back nearly to normal. And this is a case presentation as an example. He was a boy diagnosed as type 3 Gaucher disease, L4B homozygous, and starting the enzyme replacement therapy in November 2006. Initially had failure to thrive, progressive organomegaly, anemia, and thrombocytopenia with occasional bone pains. As you show, there is marked improvement in the anthropometric weight, height, hematological, and somatic parameters as regarding the hepatic and splenic volume on the enzyme replacement therapy. And during his follow-up, an emerging problem is shown during the pelvic abdominal ultrasound as enlargement of the mesenteric lymph nodes, marked enlargement, which pressure on the mesenteric artery, for which a high-resolution CT was done and biopsy, and it revealed Gaucheroma. For this child, we make fractionation of the enzyme replacement therapy and adding an oral steroid dose, and this child show nearly disappearance of the mesenteric lymph nodes and the Gaucheroma, with marked improvement of the quality of life and the radiological scan of this child. And in 2019, he had improved the somatic hematological manifestation, no lymphadenopathy on pelvic abdominal ultrasound with normal growth. Again, the enzyme replacement therapy improves the bony symptoms, both clinical bone crisis, bone mineral density, fracture occurrence, and the necrosis of the head of femur. And so it improved the health-related quality of life because of decreasing all these bony manifestations. Is there benefit for beginning the enzyme replacement therapy early? Yes, because the delay in the treatment allow seemingly mild or absent disease to progress to a point where irreversible manifestation, such as osteonecrosis, joint collapse, fibrosis of the visceral organ, which when we start enzyme replacement therapy, it will not be reversed. And this is an example for the effect of the early treatment of the enzyme replacement therapy. This child, date of birth July 2009, and diagnosed as having type 3 Gaucher disease at the age of 3 years and 6 months with progressive abdominal enlargement, and diagnosed by the enzyme SE and bone marrow. He started the enzyme replacement therapy. At the start, he had only delayed motor and mental development, mild ophthalmoplegia, and mild mental retardation. At the start, he had progressive improvement of the anthropometric, somatic, and hematological manifestation. And on March 2017, as you see, he had re-increase in the hepatic and splenic volume, recurrence of anemia, and thrombocytopenia. So there is a recurrence of the manifestations as the start of the disease. We think to re-evaluate our patients both clinically and radiologically. Clinically, he had respiratory distress, massive distressing abdominal distension, huge splenomegaly, and bilateral shifting dullness, positive indicating ascites with marked tender hepatomegaly. And laboratory, he had anemia, microcytic hypochromic, elevated transaminases, antibodies to IgG serozyme were negative, serum albumin low, 2.5, hepatitis B surface antigen and anti-hepatitis C were negative with prolonged PT and activated partial thromboplastin time. Pelvic abdominal ultrasound showing distorted morphological appearance of the liver with nodulation and suspect Budd-Chiari, veno-occlusive or liver cirrhosis. And 2 weeks later, this child presented to the ER shocked with massive bleeding and hematemesis from the esophageal varices, hemoglobin 5.4, upper GI endoscopy showed grade 2 esophageal varices, and the duplex diagnosed liver cirrhosis with portal hypertension and splenomegaly. At this time, we make a supportive treatment, diuretic, fresh frozen plasma, vitamin K for this child, and now this child had a compensated liver disease, improved somatic and hematological manifestation on enzyme replacement therapy. He started the enzyme replacement therapy early. When we talked to the mother, we found that he had a positive family history with an elder brother, elder by 4 years, had anemia and hepatosplenomegaly, died at the age of 5 years by an attack of variceal bleeding. And as you show, he made a complete hematological workup. He was tested for hepatitis B, C, HIV, Wilson, autoimmune liver disease, cholestatic liver disease, all were negative. Even he is tested genetically for hemochromatosis, and no one think about Gaucher disease, and he is died undiagnosed. Also, the enzyme replacement therapy affecting all the hematological, somatic, and bone manifestations, and it affects also the disease burden, which is reflected by decreasing the chitotriosidase level in children treated by enzyme replacement therapy. Another example of our patient, this is a male patient diagnosed as type 3 Gaucher disease, homozygous L44B. He started the enzyme replacement therapy on September 1999. His main complaint was bony manifestations. He had limping gait due to old fracture, and he had X-ray manifestation of Erlenmeyer flask deformity, which is denoting severe osteopenia, and he performed splenectomy on 1995, and after that he had severe bone pain, recurrent crisis, and pathological fracture of the right femur. He started the enzyme replacement therapy with improvement of all the hematological, somatic, and gross delay manifestations. This is his initial X-ray, severe osteoporosis, Erlenmeyer, fracture neck femur, knock-knee deformity, bone mineral density was very low, and the MRI shows left-sided patellar dislocation. This is after 5 years of enzyme replacement therapy, nearly normalization and improvement of the bone mineral density on the plain X-ray. And on March 2019, no symptoms regarding bone pains. Clinically, he had no pains, no bone crisis, only mild limping gait due to old fracture, and marked improvement of the radiological manifestations. This child is diagnosed at the age of 2 years, although he had negative family history and non-consanguineous marriage. Initially, his main complaint is that he was transfusion dependent, severe anemia with repeated red cell transfusion since the age of 7 months, frequent chest infection, which necessitating hospitalization by pneumonia, and wheezy chest. He had also anemia and thrombocytopenia, and initially in his echo, he had pericardial effusion in the echo at the start of the therapy. After he started only on small dose of enzyme replacement therapy from 10 to 15, he had disappearance of the pericardial effusion, mild improvement of the chest condition. But he started the full dose on 60 units per kg on January 2015 with marked improvement of the ophthalmopraxia and regression of all the somatic manifestation and marked improvement of the pulmonary manifestation. This is his sequential follow-up with improvement of hepatic splenic volume and anemia and thrombocytopenia. Gross parameters markedly improved. And this is his initial CT chest marked infiltration by Gaucher chest for the pulmonary affection with marked repeated severe infections. On ERT, he had marked improvement. The patient become don't need for hospitalization for the severe pulmonary infection. And many literature reported that in type 3 and type 1 Gaucher disease, enzyme replacement therapy causes some improvement of the respiratory manifestation, including even the pulmonary hypertension. But during his regular follow-up, he developed some manifestations of abdominal obstruction in the form of severe abdominal pain, abdominal distension, pelvic abdominal ultrasound and CT done, and it revealed mesenteric lymphadenopathy making intestinal obstruction for which surgery was done, and the biopsy revealed Gaucheroma. And again, we make for this child fractionation of the enzyme replacement therapy to be every week. The child was very compliant, mother very keen, with disappearance in the follow-up pelvic abdominal ultrasound of the mesenteric lymphadenopathy. Now he had very good response to the enzyme replacement therapy. He is in school with normal mentality. Regarding the safety, because we are pediatrician and the safety is number one, the enzyme replacement therapy is very safe and effective. The main complication is related to the infusion-associated reaction. Only 15% develop antibodies against the imiglucerase treatment. The dose is 60 units per kg once every 2 weeks, but also we can individualize the dose or make fractionation according to the morbidity which occur to the Gaucher patient. Take-home message: the majority of patients with Gaucher disease present with unexplained splenomegaly and or thrombocytopenia. You should make a suspicion for Gaucher disease in order to diagnose, and the reason for the delay is mainly the heterogeneous presentation, and we should help to raise the awareness of Gaucher disease in order to reduce the delay in the diagnosis of Gaucher disease. And at the end, I want to thank my dearest professor, Aza Abdelgawad Tantawi, which is the head of the Gaucher, and also to thank our juniors, Dr. Nihal Hussein and Dr. Khalid, and thank you so much.